This is an introduction to the Dublin approach to the problem of COVID-19. This is the 30th of March 2020, and time has come to make some progress, taking into account the words of Michael Ryan of the WHO, speed trumps perfection. And this is a slightly imperfect presentation, but it has to be done really quickly because every day the rate of infection is growing phenomenally and it has to be interrupted. And I think when I finish this, it'll give you some idea of how things can be done to make a really big difference very, very quickly and very easily. I qualified as a chartered physiotherapist in 1981. I'm a retired member of the Irish Society of Chartered Physiotherapists and a former member of the Chartered Society of Physiotherapy in the UK and the Canadian Physiotherapy Association. I have worked in pulmonary rehabilitation. 1982, based on the Papworth method of respiratory training, Benson's relaxation method. I was involved in the prevention and treatment of post-operative respiratory problems, which will become relevant later on. I've worked in intensive care physiotherapy, keeping lungs clear, dealing with people with hyperventilation syndrome, training people in breathing. I've practiced as a chartered physiotherapist in Ireland and abroad, and in private and public settings up to department management level. I have also extensive business management, marketing and public relations experience, and I am currently communicating with professionals in the public and private healthcare sectors. Of course, COVID-19 is a new problem, but it does contain some interesting aspects which we can use our past experience to defeat. And in fact, if we look at COVID-19, we know obviously the basic fundamentals, that it's mainly droplet spread. There's some aerosol surface spread. Ideally, the spread would be within a reasonable distance of the person who's infected, passing it on. Incubation period, 3 to 7 days, 14 days maybe. The average person who is infected will go on to infect another 2 or 2.2 people. The infected population is growing pretty much exponentially anywhere that it is getting out of control. There are certain features of the virus that interfere with the immune response of the host and allow it to spread. It interferes with the immune system in various different ways. I'm not going to go into the details because, as I say, time is of the essence here, and I can provide you with all of the references, obviously, for anything that is a bit more involved. There's a tremendous severity, variability in the severity of the disease. So some people have it and don't even know it, don't feel anything, and nobody's looking at them. Perhaps they're not being tested in the country where they're living. And then on the other hand, there are other people whose lives are devastated and in fact destroyed by the condition. And what I hope to do is present some interesting new ideas about this condition and show how easy it is actually to interfere with its progress. The first principles, though, I would like to emphasize are that facts beat opinions. Everyone is entitled to their own opinion, but not to their own facts. So I'd just like to say that I believe in the science. You've got to keep your eyes open. In the words of Louis Pasteur, in the fields of observation, chance favours only the prepared mind. So just keep an eye out for some of the things that I'm going to tell you and hopefully add in your own ideas as time goes by. We need to avoid comforting ideas. Dr. Asher wrote in the Lancet 1959, it's important to recognise that things are easily believed if they're comforting, and that many clinical notions are accepted because they are comforting, rather than because there's any evidence to support them. And I'm afraid that has so often been the case in medicine. So we have to put all that stuff, sometimes we have to rock the boat a little bit inside our own heads to try to make any progress. Words and labels, that's an interesting point, because the words used in clinical medicine have a tremendous influence on the subject they describe or purport to describe. They perpetuate illnesses, syndromes, and signs whose existence is doubtful, and moreover, they distort textbook descriptions to conform to the chosen word. So you may have to start calling certain things something else, not the words that you've been given or that you came up with yourself. And I think this will become obvious later on. I seem to like Asher. Dr. Asher, in our attitude to preventive medicine, we've got to be careful that too much of the can't do harm, might do good argument does not lead to an excessive prevention. We must not be so busy preventing disease that we have no time to enjoy freedom from it. And in many ways, when we look at some of the things that are being done now in the hope of preventing the spread of COVID-19, they do make life rather difficult to live, but we have to keep that in mind. It's important not to conform to ideas just because, just because. That's very important. Be Semmelweis. That's very important. Hungarian doctor, Semmelweis. He was really important because in 1846 in Vienna, when he was working at the Vienna General Hospital obstetric clinic, he found that quite a number of women actually died of what was called childbed fever. They were getting sepsis, of course, when they were under the care of the doctors. 3 to 4% when they were under the care of the midwives in the adjacent building. And very few of them developed childbed fever if they gave birth in the gutter of the street on the way to the hospital. So it looked like that they were actually safer in the street than they were in the hospital. And when a colleague was suffering a similar disease, having cut himself carrying out an autopsy, Semmelweis decided to look into that, and he concluded that the hands were the source of the problem, and washing the hands might help. He felt that there was some kind of noxious material on the hands that was actually poisoning people. And so he published his findings and tested them, of course, in the scientific way. They did work, but he was ostracized by the medical community. They were totally offended at the suggestion that anything on their hands could possibly bring harm to the patients. He was, I'm afraid, ostracized and treated really badly, ended up in an insane asylum, and apparently was beaten severely, and he died possibly of the same type of sepsis that he had devoted his life to preventing. So we should all try to be Semmelweis. It may be a little bit difficult to come up with ideas. They may sound a little bit crazy, and you may be certified as a result, but sometimes you have to stick your neck out. And so that's terribly important. Ignore the deniers. If people tell you that you're wrong, just ignore them if you can prove you're correct. It's difficult to get a man to understand something when his salary depends upon his not understanding it. And that was Upton Sinclair, very famous and very highly thought of American. Well worth looking into. Anyway, you will find lots of people who will object to what I'm suggesting because it really does change things radically, and as you shall see. You will, of course, find profiteers who will vilify. There are plenty of people who stand to make a huge amount of money out of the continued progress of the coronavirus outbreak, and what I'm suggesting will be so cheap as to be free, and knowledge is power, and they really won't like anybody to be doing this because it's likely to work if my logic is correct. And I expect that if it's not correct, you let me know. Time is of the essence. 40% more will die for every day wasted. This information, I have to get it out there so people can come back and tell me I'm wrong, or test it and find that I'm correct. And whichever is the case will be progress, certainly for me. So that's really, really important. Now, some ideas about the lung. Of course, we seem to have focused a huge amount on the respiratory aspect of this condition. Obviously, and this, I'm assuming that there'll be largely a medical audience or a paramedical audience paying attention to this initially, at least. But of course, the lungs, the fundamental smallest component in the lung, which we're concerned with, is the alveoli, the small balloon-like structures into which air is inhaled and hopefully the oxygen is conveyed across into the blood and taken around the body to be used. Of course, the alveoli are lined with living cells because they are living. They need their own oxygen in order to survive. Alveoli do tend to collapse if you just leave the lung to a normal pattern of inspiration and expiration. The lung will progressively collapse, even under normal conditions. This is the case for all mammals. And as the lungs collapse, as the alveoli collapse, of course, the lung collapses, it means that the gas transfer doesn't happen. So any air that you inhale doesn't go into those collapsed little bubble-like structures. And once they've collapsed, they're actually quite resistant to reopening. In any case, the human body, and in fact all the mammals, actually have a mechanism built in that you may remember from college, where you or the animal takes a regular deep inspiration, which is usually held briefly, and this causes the alveoli to pop open. The frequency at which the animal does this is pretty much dependent on the size of the mammal. So a tiny mammal, like a mouse or a shrew, will do it very, very often. A large animal, like an elephant, will do it very rarely. And a human, somewhere in between, will do it usually, depending on the person and the conditions and so on, will do it maybe 10 or 20 times an hour. At sleep, probably a couple of times an hour. But this is an essential feature of the lungs. They do tend to collapse. When they collapse, or if they collapse, they're difficult to reinflate. So the body has a built-in mechanism. So it allows a certain amount of collapse to take place. And then a stimulus is sent to cause the muscles to contract and expand the lungs, preventing the collapse proceeding beyond a certain point. Now, of course, there's a big problem, because if you were to have surgery, and various other things that can interfere with this natural built-in psi mechanism, this is a big problem. So if you have restrictive clothing, there's some people do wear extremely tight clothing for various reasons. Clothing can restrict the movement of the lungs, and this is a problem. Drugs, including opioids, whether licit or illicit, they're a big issue. Because you get depression of the respiratory drive. So the built-in mechanism of the body that encourages the taking of these breaths slows down or stops. So you just end up with normal, average height breaths. And this is, of course, a really serious problem in anesthetics, because, of course, the anesthetics tend to depress respiratory drive. Patients, even within 20 minutes of being anesthetized, or sometimes sooner, their lungs will be collapsing, and unless they're given a regular additional volume into the lung, they will progressively collapse. And when they come out of theatre after surgery, if this isn't reversed, they can get into a pretty sharp downward spiral, which would cause them to become hypoxic with collapsed lung, and an emergency taking place and being raced to intensive care, and it can have really serious implications. So drugs do have an effect on this. Intra-abdominal pressure is a problem, because, of course, if there is any pressure upwards on the diaphragm, that will restrict the ease with which the diaphragm moves. And of course, this for many decades has been clearly understood, because anybody would know that if you have an extremely large meal and you lie down, you can almost not breathe, because your extremely large meal is pushing upwards on your diaphragm. So sitting up or at an angle can make things easier. This, of course, is very, very important, because if people are struggling in respiratory failure, if they're struggling with their breathing, it's obviously important to make breathing as easy as possible. Neglect. When you want to avoid collapse, you've got to remember that neglect can be a cause. So if you have a patient or somebody who's anesthetized or on medication, or at risk of getting lung collapse, leaving them in the same position all the time is really not good. You've got to change position. Humans we tend to be mobile, and we're lying on one side, another side, and so on. Things, just because you're stuck in one position, that in itself is a risk factor for lung collapse, and that can be, again, a really big problem. In the context of the COVID-19 situation, if you have extremely overworked staff, or insufficient staff, and you've terribly overweight patients, or maybe you don't have any hoists with which to lift patients because they're immobilized and extremely heavy, this is going to be a really big issue. And it's something that is going to have a big impact on certain populations where they might be more inclined to be overweight, that they are actually going to get a lung collapse from simply not moving. And it's fairly commonsensical, but it's something that we really do have to bear in mind. Where people are at risk, You may need checklists, timers, supervision, people checking the checklists to make sure that the turns were done. Reminders, you may need special teams of people to move the patients, and their job would just be to move patients and not to do anything else, because they might be particularly physically fit or particularly skilled at lifting and handling, or they might have the right equipment or whatever. But keeping people moving is absolutely essential. So obesity and posture obviously have an effect on position of the diaphragm. Obesity is interesting because the weight of the fat overlying the ribs has an impact on ability to breathe. So again, if you're unfit and you suffer from a respiratory problem and then you have COVID-19 in on top of that, it may be that your respirations will be less active. And this can be a really big problem. And again, so you've got to bear that in mind. If you see somebody who is obese or who has difficulties with their posture, maybe somebody has a really severe kyphosis, they're very stooped, or they might be in a wheelchair and they might be slouching forwards on top of their own abdomen, and that's pushing up into the diaphragm, and they might be overweight. The weight of their own upper body is actually pressing in on their ribs. These things are really important. If their arms are, perhaps their own arms are actually pressing in on the ribs. And this is really important to bear in mind, because you literally can save a life by preventing collapse in the airways. Pain is another thing that's really important. If people are in pain, if they've abdominal pain or pretty much any kind of pain, they will perhaps try to avoid inhaling against that pain. So try to bear that in mind if you're looking at patients in general and you want to avoid getting collapse. You've got to make it possible for them to actually move and so on. And that's what one of the things that physios do, is teaching people how to protect themselves against pain that might actually inhibit their breathing, how to overcome that pain, how to work through it so that they can take those deep breaths regularly in order to prevent the collapse that would put them at serious risk of deterioration. Sleep apnea, which is a particularly interesting thing, because sleep apnea, of course, is very common these days, and there is, of course, the connection between sleep apnea and other conditions, including obesity and hypertension, diabetes. It's a complex relationship, autonomic dysfunction, and so on. But it's terribly important that we bear that in mind, and there has been some particularly interesting work done, like restrictive lung disease, a long time ago, 1987, just after I qualified. And really quite interesting work done on this. You see sleep in restrictive lung disease, categorizing the types of conditions, of course, and various aspects of pulmonary function that are worth looking at. But the idea that patients with extrapulmonary restriction often develop reduced chemical drives to breathe and hypoventilation, whereas those with intrapulmonary restriction generally exhibit hyperventilation due to stimulation of pulmonary vagal receptors. The pulmonary vagal receptors are extremely important, because, of course, if they are stimulated, and if you do have a hyperventilating patient, it may tell you that there's something going on inside the chest. And this is interesting, because not all patients suffering from COVID-19 actually have a sense of a sense of breathlessness, or they don't hyperventilate. They may in fact be hypoventilating, and they may be hypoxic without knowing it. And I think we'll come back to that a little bit later. The male-female link is interesting, because in the same article it was noted in a certain category that the patients with low oxygen, 8 of 10 patients were male. The 2 female patients had the most severe pulmonary function abnormalities, yet they desaturated very little, suggesting that might be a difference in the reaction to hypoxia between men and women, or between males and females. And in fact, that again fits in rather interestingly with the sudden infant death syndrome connection, because again, wherever you look, there is a 50% excess of male infant mortality from sudden infant death syndrome and other respiratory diseases, suggesting an X linkage. So quite interesting. Different countries this has been looked at. You can see, for example, a Korean study showing the difference there between males and females. So that's something, again, which is very interesting to bear in mind, taking into account some of certainly the earlier reports that there was in some centres, there was a large male preponderance of patients suffering severely with COVID-19. So we should bear that in mind. I'm not going to go through everything in great detail. As I say, speed is of the essence, but there's plenty of interesting stuff to study if you're so inclined. But what I'm going to get at is actually really, really simple stuff later on. So, neurological issues. This is going to be very important in the context of what I'm trying to explain later on. Obviously, we have pressure receptors and chemical receptors, mechanical stretch receptors, and so on that feed into the brain stem in order to help control breathing so that it does what it's supposed to do, maintains the right types of blood gases and acids and so on in the blood. Since the blood gases have to be really, really carefully maintained in order for all the functions of the body to continue as in as healthy a state as they can. But sometimes these go wrong, and in the context of the more recent reports that COVID-19, or more correctly, the coronavirus, has actually been found in neurological tissue, having, in some cases, the suggestion is having passed through the nose into the olfactory bulb and onwards through the brain as far as the brain stem, that it in fact may interfere in some aspect of the control mechanisms for breathing. And this is absolutely central to what I'm going to tell you about, because obviously if the respiratory center or its function is affected in some way, but the focus is on the lungs or multi-organ failure and other aspects which are really quite distant from the brainstem, this would be a serious omission. And I think you would agree. Here's an example of a case study. 62-year-old male, very fit and active, regular cyclist, takes lots of walks, gout, but well controlled, moderate hypertension, never smoked, moderately overweight with a BMI of 26. Retrospectively, had a record of a flare-up of gout for about 2 weeks, metallic bitter taste on the tongue for some days, 7 days or whatever, vague myalgia, flitting from place to place very, very quickly, an overall sense of weakness, headaches, slight fatigue, balance issues that were put down to the gouty toe probably interfering with balance, never ever breathless, unable to proceed on a particular cycle, no sense whatsoever of dyspnea, no awareness of breathlessness, but simply not able to proceed. No increase in respiratory rate at all when cycling, not even the normal respiratory rate that you would expect when cycling hard uphill. Returned home, checked pulse oximeter and found it was as low as 89%, but no sense of breathlessness. In fact, the respiratory rate at rest 20 minutes after all this cycling and so on, was 9 breaths a minute, with no desire to increase the rate or depth of breathing, despite 89% oxygen saturation. Not the best. Absolutely no size, complete absence of any normal drive to occasionally reinflate the lungs. Knowing what to do, deep breath holds at maximum inspiration several times. So it will be a really maximum inspiration, hold the breath for 3 seconds or so, and then let it out and repeat that several times. So the saturation gradually improved within an hour, but still falling back at times, certainly in the early stages of this, procedure. And after a few days, still 90% on waking in the morning, but typically 97, 99%. Moving around seemed to actually make it get to 97, 99%, which may have been a response to peripheral mechanoreceptors stimulating a more normal breathing pattern, as opposed to the other receptors that may in fact have been impacted by the virus. But there was no fever, minimal dry cough. It was not possible to get tested for coronavirus or anything else. GP practitioners are inaccessible, hospitals inaccessible, and self-management was the only option. In fact, telephoning the coronavirus helpline with the usual response that people seem to be complaining of in Ireland, which was, well, just stay at home, close the door, stay in, and ride it out. So the regular reinflations went on. Inspiratory muscle training using a power breathe device from the UK, which is just one of the many inspiratory muscle trainers that are available. And this led then to the assumption that a neurological insult of some sort changed the respiratory drive in some way. Respiratory center, who knows? Chemo, baromechanoreceptors, not important really at this point. The key thing is that restoring normal maximum inhalation and holding it was absolutely central to the solution. So there's 89% at a pulse rate of 103 after cycling. So not really a great way to be when you're normally very, very fit. And so that's a really important and not the only such case. In fact, within a couple of days, it was obvious that it was somebody else with a similar case, and there have been reports from neurologists now coming in saying that actually it is absolutely essential to look at the neurological aspect of the problem, the potential neurological aspect of the problem. Now, looking at the brainstem, again, we see that the 27th of February, there are already reports of the neuroinvasive potential of SARS-CoV-2 and may be partially responsible for the respiratory failure of COVID-19 patients. So this was reasonably early on, coming in the Journal of Medical Virology, and so that's certainly awareness of this will have important guiding significance for the prevention and treatment of the SARS-CoV-2 induced respiratory failure. Now, I don't think it's got a huge amount of attention really, because any of the people I've spoken to are really more interested in getting more and more ventilators out there and not actually trying to find some simpler approach that might actually be able to be implemented, because you're just not going to get enough ventilators for the stunning number of patients that are likely to turn up. Now, Dr. Avi Nath has a really, really, really interesting podcast, which you can look up online, and he speaks very, very clearly on this, and I do recommend it. Neurology podcast. If you look up Dr. Avi Nath, you would actually find there's a podcast. Dr. Avi Nath. Yeah, I won't play it now. I could play it now, but it would just delay you. If you're interested, have a look at it. It's extremely interesting. It's half an hour, and you can play it at faster speed if you wish, but it is absolutely, it should be essential listening for anyone who's interested in dealing with COVID-19. It just opens up the whole thing and gives the explanation exactly the way you would want it. So I do recommend that. Right, so not really much need to go into so much more detail there. Talking again about the role of atelectasis, collapse and so on. It's interesting that in other conditions, essentially the same story as we see panning out with these patients with COVID-19, with a lot of them. The type of damage that's caused it really does correspond with the kind of symptom patterns and signs and so on in those who've been asphyxiated or had severe sleep apnea, hypoxia, the kind of insults that take place, the fact that the lung tissue itself requires oxygen, and when it's deprived of oxygen, the lung tissue actually degrades in its ability to fight infection and to behave in a normal way in response to virus, or even to make the person more prone to taking in more pathogens, even bacteria and so on. So the risk of pneumonia increases because of, and bacterial pneumonia, because the tissue lining the lung is actually damaged. The surfactant, which should be making it easy for lung units, alveoli, to pop open again, having been closed. That surfactant is like a detergent lining the airways. That can be also degraded as a result of the hypoxia itself. And the inflammatory response can really be overwhelming at a certain point. And of course, we end up with this cytokine storm that everybody is terrified of. But of course, if we can find some way of preventing the anoxia or hypoxia affecting the alveoli in the first place, then the chance of actually preventing people from moving closer and closer to intensive care would really be of great benefit. Right, moving on swiftly, because we do have to be swift. It's very, very important that we actually try to get to some kind of implementable solution here. And I think it's safe to say that the alveoli, and probably some kind of neurological insult causing a change in respiration, especially when people tend to be more immobile. So I've often thought of people sitting around watching television these days, because there's not much else to do, sitting around watching television with a tendency to underinflate their lungs, affected by obesity, which tends to make people less likely to inflate their lungs, less physically active people who tend not to inflate their lungs because they don't really move around very much. And then they retire to bed for the night, and during the night they're not aware of pretty much anything, and nobody notices the fact that they're not taking the size that are required by the body to re-inflate those collapsing alveoli, because they're always collapsing, and you always have to have a size every so often to re-expand them. So it just means that in a particular evening, followed by a night, you might actually propel yourself into intensive care just in that period, because you've collapsed your lungs for long enough to actually degrade the lining of the alveoli, more likely to get infection. The surfactant is kaput. It's very hard to get these reopened again. And when pneumonia hits, then of course you end up with a fever. So while you may have started off with no fever, suddenly you've got a fever, you've got huge demand for oxygen directly because of the fever, of course, or shivering. Shivering really increases the oxygen demand dramatically. But you still are a relatively inactive, relatively overweight person with collapsed lung. It is just a perfect storm. Bacterial infection, totally out of control, surrounded by people in a similar situation. The staff are totally overstretched. There's simply no way that they're going to be able to do anything tailored to your needs. Put you on oxygen, put you on lots of oxygen, medicate you with this or that, and you're on your own, you're away from your family, and you're looking into the abyss. And it really is a harrowing prospect that's there for anybody who actually goes down this particular road. And I think if we just bear in mind everything so far for a moment about the need to re-expand those alveoli, how are we going to do that for people? How are we actually going to get people to do that? And actually, physios were doing this for decades. In hospitals, patients were going for major surgery, major abdominal surgery, at very high risk of lung collapse. And the physio would go in before the patient ever got to surgery. They'd be advised on what was going to happen, what the surgery was going to be like, what the various bits of equipment were, and the exercises and the activity that they would need to do very, very soon after they came out of surgery. So the first person that they saw when they came out of surgery, hopefully, was the same physio who had taught them how to do their breathing exercise, and who would say, well, you do remember what I showed you before? Now you're going to do it. So despite the incisions and so on, they would know what they were going to do, and they would put it in place. And those who did that had to, obviously, and it's proven time and again, I mean, I think anybody who's worked in clinical practice would know that it works, and if you don't, I'll provide the papers here. But it's just beyond important that we get this going. And it's an emergency, actually. Yeah. So what can people do? We can implement a plan so that everybody is told that this is what they're going to do. Members of the public can be told. The public at large can be told. There's no reason why national sporting bodies can't enlist the members, the children in the organizations, the teenagers, teach them how to do it. They can teach their grandmothers how to do it. Make sure that everybody does this so that even the people who might be old, might be at risk, might be infirm, might be overweight, might be diabetic, might be smokers, might be male, seeing as that's felt to be a risk factor, that these people actually do this. It merely is a case of, during the waking day, taking a couple of really deep breaths, holding them for 3 or 4 seconds, yeah, every hour. Nothing dramatic beyond that. Not hyperventilating, not getting into a whole big long sequence of deep breaths that might make you dizzy and, suffer a fall or headache or whatever. And this might be all it takes. Who knows? Until the virus passes over and normal respiratory drive resumes. But if we don't do that, if we don't get that particular thing out, I think that an awful lot of patients have no escape. These are the people who feed into the far reaches of the 80%. The 80% who are supposed to be suffering mild illness. Every person who's got severe illness has been a patient with mild illness. So the only way to cut off the severe illness is to get somewhere into the mild illness and not to be dealing with this problem as one where ventilators are needed or coffins are needed. We need to be going back where a postcard in the post received by somebody in a rural location saying, these are some useful exercises you can do, just useful activities. Do more moving around the house. Sweep the floor, sweep it again. Be very active, be as active as you can be. Don't watch television all the time. Go up and down the stairs a few times. Go out into the garden and dig some potatoes or whatever. Staying active is absolutely central to this because physical activity increases the activity of the immune system, normalizes the immune system. And in this particular case, I think it's actually very likely to actually help with expansion of the lungs and the mobility itself, bending down to plant a few potatoes or whatever, would be good exercise, would help to get things moving inside the chest. So the likelihood of having normal blood flow, which will deliver the immune system components to the right place, as would be expected for humans, that is more likely to take place. A good diet, of course, is terribly important. And much has been said of the shortage of omega-3 in the diet in certain countries and the preponderance of omega-6 in the diet, which is said by some to be a disadvantage. Vitamin D in the Northern Hemisphere is a big problem. We don't get much sunlight in the Northern Hemisphere. Sometimes we don't get any sunlight. And it's suggested that vitamin D is an important part of maintaining a healthy body. But they would be in the dietitian's field, which is not mine. I'm talking about the physical world here as a physiotherapist. Just moving on swiftly to some ideas about the role of stress. Stress really has a major impact on the immune system. And very, very important to bear in mind that by improving the immune system of those who are least affected by the virus means that the viral load that they take in and the virus load that they produce will actually be reduced. So again, you can actually literally control the amount of exposure within the community by making sure that each member of the community is as healthy as possible. And stress does, and of course at the moment it's extremely stressful. People are now unemployed and possibly have lost their businesses, at risk of losing their homes. Everything that they've known is in danger. It's an extremely stressful time for pretty much, anybody who knows about this condition. And so that's literally billions of people at the moment. So dealing with that, trying to find some way to actually help people suffer less stress, and particularly in the healthcare sector, because the type of stress that healthcare workers are exposed to in the coming weeks, especially as if the condition is left to grow out of control, the prospect of people changing their style of practice completely, doing things that they never thought they would ever do, making decisions that they never thought they would ever make, knowing that if such and such, then things would have turned out differently. for them and for their patients. And the fact that they will make mistakes in their practice, and their mistakes may cost lives, but perhaps they couldn't have done it any other way. They couldn't have been expected not to make mistakes because they'll be under so much pressure. But of course, they will carry with them the guilt, the mistakes made. They will never forget those. And this is just a well-known phenomenon. How could it be any other way? So we really need to cut down the exposure of healthcare staff to stress. We need to stop the rise in the number of patients so the healthcare staff are not exposed. And of course, if they are exposed to excessive stress, they are much more likely to be infected because they'll make mistakes. They'll make a mistake with their PPE and that's it. They're just going to get the virus and then they're going to be in trouble. They'll be one of the people in the intensive care bed if this isn't handled correctly. Hyperventilation syndrome is terribly important because, according to some writers, many writers indeed, over many decades, patients who tend to hyperventilate and suffer from dysfunctional breathing, they would make up a significant percentage of the populations in any GP practice or even in any accident and emergency department. Because of course they do often get chest pain, they often get difficulty breathing, they get a lump in their throat, they are sometimes visibly hyperventilating. There is definitely going to be a risk of an overlap between patients suffering from hyperventilation syndrome appearing like patients suffering from COVID-19. And it's extremely important that people try to develop an awareness. I won't go into it now, but you can certainly look it up, and I'd be happy to put up some more information on this. But it's very, very important to try to make sure that none of the people who are suffering from hyperventilation are inadvertently treated as people suffering from COVID-19, especially in the absence of any proper testing, and where people are under such pressure that they will simply make a quick decision and propel a hyperventilation syndrome patient into the path for COVID-19 management, which would be totally wasteful of resources and obviously not the thing to do. So very important. I hope that staff triaging patients are being made aware of this. This is a really big thing. If it is, as many have said over the decades, 10% of people in GP, I put my money on it being even more likely that they will turn up in the COVID-19 pathway. And of course, we're well familiar with the effect of post-traumatic stress disorder. These, of course, the post-intensive care unit disorder affecting people who are unfortunate enough to end up in intensive care. They really do have problems afterwards. Life is never the same afterwards. Certainly for the majority of patients, it's not the same. For some of them, it's a lot worse. And they see things that they can never unsee. And that's happening. Anytime you look at the television now, there are things that we can never unsee about this condition. So it's really, again, another reason why we have to stop people from getting into that situation. That there is hope. People can be active in how they handle their risk of getting this condition. They can be active in how they handle the progress of this condition. Because if I'm correct, and atelectasis, lung collapse, is behind a huge amount of the problems, the tendency towards ARDS, that can be interrupted. Physios have done that for decades. There are so many thousands of patients, millions of patients, who never got to intensive care because of the simple procedure of getting people to overinflate their lungs a little bit when they come out of surgery. It was a very, very simple procedure. Millions of people didn't have clots in their legs as a result of the exercises that they were shown by the physios. It's in the same way as dentists and dental hygienists and toothbrushes. Toothbrushes really do prevent a lot of people needing full sets of implanted dentures. So sometimes it's the really, really simple things that matter and not so much the expensive. It's not the ventilator at the end of the ICU process, but actually the thing that keeps people out of getting into that pathway in the first place. And I think that's really important, and it's also very positive because it doesn't cost anything. It's a technique. It's stuff that anybody can learn. Physios are teaching lots of people this over decades, and it worked, and all the evidence is there to show that it worked, and continues to. It doesn't matter how often they actually try to examine it and see if it works. It's always proven that it works. So expanding your lungs, preventing atelectasis, keeps you out of the pathway for getting ARDS. And I really think that this is something that has to be looked at. As I say, it's cheap. So cheap, it's almost free. And it's something that can encourage people that they really do have much more control over this problem. Not wishing to go on about alveoli, but they do progressively collapse, even under normal conditions. Yeah? And the collapse is normally prevented only by sighing. This is terribly important. The volume in the lungs, if you see here, typical breath, let's say it's half a litre, you would normally take these normal breaths, inhaling, exhaling, and resting. So inhalation takes work. Exhalation is elastic recoil of the chest. And then there's a rest period, usually, when there's no muscle activity. Then there's a large inhalation we call a sigh that can be held for a moment or two by the body, and then that's released again under elastic recoil. And then there's usually a slightly longer period before the next normal inhalation, and it just resumes again. So it could be 10 per hour when you're awake and 2 per hour when you're asleep. People who tend to be very, very anxious would increase the frequency. And other animals do it. We all see cats do it and dogs do it and so on. It's pretty much a standard feature of mammals. In fact, it's innate in all land mammals. There's a very nice paper here, a quick guide on sighing and current biology, which will tell you everything you need to know really about the history of the discovery of sighing and some technical aspects of it. But again, no need to go into it here. You don't have to take my word for it. But 1964, effect of morphine on breathing pattern was one of the nice original papers that had a big influence on me in my early years as a physio. 1964, JAMA, effect of morphine, Egbert, Ben Dixon, and explaining that since severe post-operative pain must be alleviated, measures to reduce or prevent pulmonary complications should be considered. These include vigorous encouragement to do breathing exercises, use of forced deep inspiration with a bag and mask, and regional anesthesia to block pain locally. So these are different measures for reinflating or maintaining the degree of inflation of alveoli. Terribly important. Different ways of doing it. People set up ventilators to do it. They bag differently. If they're using an ambu bag, they hopefully will take these breaths occasionally themselves, both when they're asleep and when they're awake. But this is central to what I'm saying. If you don't do this, you're really in big trouble. Yeah. And we just don't want to have big trouble. So there's a cheap way of dealing with this problem, and I think it's time to really just go and implement it. Another quick comment, an attempt to represent alveoli diagrammatically, gases in and out, alveoli, collapsed alveoli, which are difficult to reinflate, which transfer less oxygen, obviously, inwards or have less oxygen in there, so the cells are damaged, lining the airway, less surfactant, reduced immunity, less protection against infection, greater risk of pneumonia. But here's an interesting point, which is that collapsed areas can be painful when reinflated. This is a really important point. So the collapsed areas, until they're reinflated, may be completely pain-free. But as soon as they're reinflated, so again, you have patients with coronavirus waking up after a night of progressive collapse, and when they take their breaths in the morning, they get this dreadful pain that has been reported in the media and so on, this extraordinary pain, which isn't really common with a lot of lung conditions. So this wouldn't necessarily be the pneumonia being painful, but in fact the reinflation of collapsed areas. Now, without going into too much detail, pain tends to be pro-inflammatory in and of itself. So areas that are actually painful tend to be more likely to become inflamed. So we could be looking at a vicious circle effect here, where the pain itself actually provokes an inflammatory response within the tissues, and this could be part of the slippery slope that people get on. So again, as I keep harping on about keeping the alveoli open, a really aggressive approach taken on that. There are apnea apps available for telephones, for smartphones, where the phone will actually sound an alarm if you don't move. These could be rolled out very, very quickly. Some of them I've seen have had like 10 million downloads. So they're fairly easy to see. I'm sure somebody come up with these in any language that is needed pretty quickly. Other family members could also play a part here. So if there's a possibility of children reminding their elders to actually do this, this would be a really, really interesting thing to see, because, as I say, lots of people could be doing this in no time at all if this is proven correct. And to be totally honest, I can't see any reason to not do this, because there are no side effects that I can think of. I've been thinking of potential side effects, and as long as you don't hyperventilate, unless you've had a recent rib fracture or a recent pneumothorax, the chances of doing anything wrong by taking a couple of really deep breaths and holding them for a few seconds every hour, I just don't get any objection that there might be to that. Rolling this out in a prison population, for example, and knocking the problem on the head would be a very, very nice thing to do, because there's such a fear and the fact that people can't escape. In fact, maybe they can not just not escape from this condition, maybe they can actually take over the condition and stamp on it in the prison by implementing this kind of thing. So I think the time has come to stop being afraid of the boogeyman and take on the boogeyman with science. It's the only hope we have. Finally, my name is Pierce. I'm a chartered physiotherapist. My telephone number is +353 87 245 3118. And the email you can get back to me with your suggestions or objections, info@physio2go.ie. Thank you, and I'm looking forward very much to hearing how this can be developed.